Question number 73, pathology of pulmonary circulation. In this question, we're going to cover 4 different types of pathologies related to the pulmonary circulation. And as you would be expected to do in your exam, I'm going to follow the framework of defining the disease, classifying where applicable, discussing the etiologies, and finishing up with morphological changes and complications that you should know for each of these disease processes. So the first one we're going to discuss, first pathology we're going to discuss is pulmonary arterial hypertension. So PAH, or pulmonary arterial hypertension, is basically defined as a pulmonary mean arterial pressure of greater than or equal to 25. So the mean arterial pressure of the pulmonary artery being greater than or equal to 25 millimeters of mercury is defined as pulmonary arterial hypertension. And this basically results when you have an imbalance of vasoconstrictory and vasodilatory an imbalance between vasoconstriction and vasodilation mechanisms is more often than not the underlying etiology of pulmonary hypertension, and they can be classified into 5 different types based on the etiology. So, type 1 pulmonary hypertension is characterized by an increase in vasoconstrictory mechanisms or a decrease in vasodilation mechanisms. And so as far as this is concerned, all you need to know are some of the causes of why this may happen. First one is it can be completely idiopathic. And to classify the disease process as an idiopathic process, this is normally done as a diagnosis of exclusion. So once all of the other causes of pulmonary hypertension that we are going to discuss in the next few minutes are completely ruled out, that is when you say that the disease process is idiopathic. There is no identifiable cause. Second cause is this can simply be a hereditary process, and this is most commonly associated with a mutation in the BMPR2 gene. It can be further associated with connective tissue diseases. An example would be scleroderma. And scleroderma is basically an autoimmune disease that causes inflammation resulting in fibrosis or thickening of mostly the skin and other areas of the body, one of them being the lungs as well. And another cause could simply be a left to right shunt, which is basically a result of a congenital heart defect. And so that is what falls under the umbrella of type 1 pulmonary arterial hypertension. Now, type 2 pulmonary hypertension is basically pulmonary hypertension again that occurs secondary to left-sided congestive heart failure. And the basic pathophysiology that is important to know in this case is that when you normally have left-sided heart failure, blood will start backing up into the pulmonary veins, rather through the pulmonary veins, and back into the capillaries of the lungs. This in turn then leads to pulmonary congestion, which then leads to pulmonary hypertension. And that is pretty much it. Type 3 pulmonary hypertension occurs secondary to underlying lung disease processes. And examples of lung diseases that could be associated with causing pulmonary hypertension include COPD and interstitial lung diseases. And the underlying pathophysiology behind this is that because of these lung diseases, whether it's COPD, whether it's interstitial lung disease, it results in poorly ventilated alveoli. And as you would remember from physiology, if you have an imbalance between the ventilation and the perfusion, in this case you have decreased ventilation, you will have vasoconstriction of the alveolar vessels to shunt blood towards alveoli that are better ventilated. And if you can imagine, depending on the extent and the degree of the lung disease at question, whether that's COPD or ILD, again, a diffuse or localized vasoconstriction can lead to pulmonary arterial hypertension. Now, type 4 and type 5 pulmonary hypertension are basically classified based on the fact that they occur secondary to pulmonary embolism. That is for type 4. We'll discuss that, as that is one of the pathologies that we need to cover in this question. And type 5 pulmonary hypertension occurs secondary to any underlying malignancies. Again, you can imagine if the malignancy or if an embolism is jacking up and blocking a vessel, or it's completely damaged a vessel and you cannot get blood flowing through there, you have an increased resistance, and increased resistance in any of the vessels in the lungs will result in overall increase in the pressure at the level of the pulmonary artery. And so these are the 5 different types of pulmonary arterial hypertensions classified based on their etiology. You should be able to just give a brief overview of these of this classification. You don't really have to go too much in depth into explaining what heart failure is, how it occurs, or what COPD is or ILD is, because these are separate questions as is. But for the sake of connectivity, you should, and for the sake of the overall picture and a holistic view, you should be able to mention these secondary pathologies as a cause of pulmonary arterial hypertension. And so now we are going to discuss some of the morphological changes that take place due to an increased pulmonary artery pressure at the level of the heart and at the level of the pulmonary artery itself. So, as was the case with regular hypertension, and I'm going to do this in yellow because these are morphologies we are discussing. As was the case with regular hypertension taking place, an increased pressure on the walls of the blood vessels will result in damage to arterial walls. And when there is damage to arterial walls, you normally have the process of atherosclerosis taking place. So atherosclerotic plaques can be seen at the level of the pulmonary artery on autopsy and more. And that is one of the morphological changes that do take place. Obviously, atherosclerosis also has a lot of other predisposing factors which you should know from the vascular pathology section, but for now this should be it. The second important morphological change that we need to discuss is smooth muscle hypertrophy of the pulmonary artery, and this is basically occurring in response to this increased pressure. As was the case with regular arteries, when you normally have an increased blood pressure, you will have a reactive smooth muscle hypertrophy as an adaptive response to the increased pressure. Now, in long-standing and chronic pulmonary hypertension, you can imagine if there is an increased pressure, the heart technically has to work harder to pump blood against this higher pressure. And at this point in time, we're concerned about the right heart. So, in cases of chronic or long-standing pulmonary hypertension, the right ventricle undergoes hypertrophy, and this is concentric hypertrophy to be exact. Simply as a response to pump blood against higher pressures. However, if this long-standing pulmonary hypertension keeps going on post the fact that the heart has already adapted to it through hypertrophy, this adaptive response will also fail and will result in right-sided ventricle dilating. So you will have dilated cardiomyopathy of the right side of the heart. So the adaptive response, the concentric hypertrophy response, will eventually fail if the long-standing pulmonary hypertension is not treated or is not, resolved. And because of that, you end up having right ventricle dilation. And this is a form of eccentric hypertrophy where the walls get thinner. And an important terminology that you should know is related to when you have right-sided heart failure. So right-sided heart failure that occurs secondary to any lung pathology. The term that we use to describe this is known as cor pulmonale, however you want to pronounce it really. And so this is a major complication that is associated with pulmonary hypertension. Over time, you can have cor pulmonale, also known as right-sided heart failure, occurring secondary to a lung pathology. The lung pathology in this case simply being pulmonary arterial hypertension. And so an important thing to note is that cor pulmonale can also, as a result, occur secondary to left-sided heart failure, because left-sided heart failure results in an increased pressure, increased backing up of blood into the pulmonary circulation, resulting in an increased pulmonary arterial pressure, which in turn puts more load on the right side of the heart, and thus right-sided heart failure can be secondary to a lung pathology that is associated with left-sided heart failure. In simple terms, left-sided heart failure can cause right-sided heart failure. And that should pretty much be it for pulmonary hypertension. Now, coming to pulmonary embolism, you firstly need to be able to define and rather differentiate between an embolus and an embolism, because these are two different entities that we need to discuss. So as far as definitions go, an embolus is basically an intravascular mass that is carried by the blood from point of origin to a distant site. So intravascular mass that is normally detached. It can be solid, it can be liquid, and it can be gas, which is carried in the blood from a point of origin to a distant site. And an embolism is a term, or rather the term embolism is basically the process by which an embolus moves in the blood. And so just those two definitions to really clear out the difference between them in a very simple way. Now, as far as etiologies are concerned with pulmonary embolism, it is the same as the causes of embolism at any other part of the body and any other blood vessel. So this is not something that's too different, and this was covered in the embolism section in general pathology. So a really quick overview. In the case of a venous thrombus, which because technically speaking, for an embolism to get to the right side of the heart, you would imagine that because blood goes from the veins into the right side of the heart, and the right side of the heart is what connects to the pulmonary artery, you'd imagine that it has to be a venous thrombus that we are concerned about in this case. And so the first etiology is a deep vein thrombosis, or a DVT. This is the most common cause of a pulmonary embolism. And why deep vein thrombosis occurs? There are three major reasons that are classified by Werker's triad. This includes blood stasis, it includes endothelial injury, and it includes the body in general being in a hypercoagulable state. And some pathologies that may be concerned with the body being in a hypercoagulable state include adenocarcinomas, as some tumors can secrete factors that promote coagulation. Factor V Leiden mutation is another cause, and nephrotic syndrome is also associated with the body being in a hypercoagulable state. Right, other etiologies that are less common but also possible in causing a pulmonary embolism include long bone fractures, in which case you have fat globules that serve as an embolus, an air emboli introduced in the case of catheterization, for example, or just a simple venopuncture, and the third one being amniotic debris in pregnancy. And so all of these are potential etiologies as to why a pulmonary embolism may occur. So I'm going to use this diagram to explain all of the morphological changes that you need to be familiar with, and some of the pathophysiology you need to be familiar with respect to pulmonary embolism. The first one is, and rather all of these presentations are really dependent on what type of embolism you have and where exactly the emboli is launched within the pulmonary artery tree. And so the first one is if you have an embolus that is lodged up in one of the pulmonary capillaries or the alveolar capillaries. Because these are relatively very small emboli, you basically have organization and fibrosis of these small emboli. In alveolar capillaries. And so as such, patients who have this normally do not have any clinical presentation, and this is normally said to be clinically silent. Right? Now, as far as pathophysiology is concerned, we discussed a bit about it just previously, but if you have small multiple emboli, you'd imagine that there will be some form of VQ mismatch, simply because you cannot perfuse the pulmonary capillaries distal to this obstruction taking place. And so you will have an increased pressure occurring proximal to the block, and where there is increased pressure, you run the risk of pulmonary hypertension, pulmonary artery hypertension. And this then, as a result, as we just discussed, will result in hypertrophy of the right heart. And so this entire process is basically what we had defined and described to be chronic cor pulmonale. So this scenario that I've described to you is what occurs in chronic stages where you have small multiple emboli. Right now, in acute phases, in acute conditions, changes that we need to talk about are related to something we call a saddle embolus. Right, and this, as the term suggests, is a saddle shaped embolus that basically ends up blocking the entirety of the pulmonary artery as it connects to the heart. So literally, as described, as shown in the diagram, is how it comes up, and it completely blocks any blood flow from the right side of the heart to either lungs. Right, and what's going to happen in this case is that you will have the right ventricle dilating immediately, instant dilation. So the right ventricle dilates instantly, and the issue with this is that due to this instant dilation, you end up stretching the conducting fibers that are present in the heart. And as you know, the right side of the heart is origin to the sinoatrial node as well. And so if you imagine you end up stretching these conducting fibers, you're basically damaging these cardiomyocytes. And as a result, because of this damage, because of the stretching of these conduction fibers, you allow for ions to leak in and out of the cell. Once this happens, this results in malignant arrhythmias. And because of these malignant arrhythmias occurring, the patient dies straight away. So instant death is what occurs. And because there is a complete forward obstructive failure and the patient instantly dies, what you need to remember for this is there are absolutely no morphological changes that are seen in the lungs. The heart itself will dilate, yes, but as far as the lungs are concerned, there is absolutely no morphological change, and this is something that is very important to understand. No morphological changes take place in the case of a saddle embolism because there is not enough time for it to happen. The patient dies straight away because of malignant arrhythmias. So complication is malignant arrhythmias occurring due to saddle embolus, which kills the patient before they can actually have any sort of morphological changes that would be seen in an autopsy in the lungs. I hope that was clear. So now coming to the last thing that we need to discuss as far as pulmonary embolism goes is the least common manifestation that you can see, and this is an infarction. It is the least common manifestation you're going to see. Now the lungs are one of the organs that benefit from a dual blood supply. So you have one blood supply of the pulmonary tree and the second blood supply that comes from the bronchial arteries to the lungs. And because of that, you'd imagine, like if I have an embolus and there is no blood flow distal to it, ischemic necrosis will occur, right? But because the lungs have a dual blood supply, the type of necrosis that occurs is a hemorrhagic necrosis. And so as far as morphology goes, you will have a wedge-shaped. Wedge-shaped is something that you should be very familiar with in terms of infarction presentation. You're going to basically have a red wedge-shaped infarct. And the apex of this infarct points towards the point of obstruction, as it would in any other obstructive ischemic necrosis. And that should basically cover the major manifestations that are seen in the case of a pulmonary embolism. In chronic cases where you have small multiple emboli, a VQ mismatch will result in hypertrophy of the right heart. We term this chronic cor pulmonale. If you have multiple small emboli as well, then obviously another possible manifestation is that they undergo organization and fibrosis, which basically is clinically silent, so you will not really have any presentation on the patient that you should be worried about, at least from the clinical point of view. The third manifestation is a saddle embolus, which just results in death straight away because of malignant arrhythmias that are caused by the dilation and the stretching of conducting fibers of the heart. And this in turn is actually what we call acute cor pulmonale. So heart failure that occurs secondary to lung diseases in this case. Obviously, like a pulmonary embolism is within the artery itself, but you get the point really. So that's how you differentiate between a chronic cor pulmonale, which is a long-standing process, versus an acute cor pulmonale, which happens instantly. And then the least common manifestation is just an infarction, and this rarely occurs because the lungs have a dual blood supply. But if it is to occur, it is going to present as a hemorrhagic necrosis with a red wedge-shaped infarct whose apex points to the direction of the obstruction. And so the last pathology that we need to, the last two rather, coming to the last one, the third one is pulmonary edema. Now, pulmonary edema is simply defined as the accumulation of fluid in the lung interstitium and alveoli. And now fluid subtypes can be divided into two. It can be transudative fluid or exudative fluid. By now you should know the difference between transudate and exudate. Exudate is more related with a inflammatory pathology, and a transudate is more related with pathologies that are not associated with inflammation specifically, but just the leakage of protein-free fluid into a specific space. In this case, that space being the lungs, the interstitium of the lungs. And so as far as etiologies are concerned, it can be divided into non-cardiogenic, so pulmonary edema that occurs with absolutely no relation to any problems with the heart, or cardiogenic, where a cardiac pathology is the reason why pulmonary edema occurs, and this is the more common cause of pulmonary edema. So non-cardiogenic rather includes any pathology that may result in an increase of vessel permeability, and this is something that is normally seen with pneumonia, which is the inflammation of the lung parenchyma due to an infectious etiology, or acute respiratory distress syndrome. There's a whole question on this in pulmonary pathology, so I'm not really going to go into too much detail, but for now just remember that these two are the causes that are associated with an increased vessel permeability. Other causes could simply be, you think logically, why would fluid leak out of vessels? And the other cause would simply be a decrease in oncotic pressure. And a decrease in oncotic pressure, we know that the main protein in the body that is responsible for maintaining our oncotic pressure from all the times Vlad probably bullied you with it is albumin. And albumin, a decrease in albumin could be secondary to liver failure, or it could be secondary to nephrotic syndrome, in which you are just losing proteins in the urine, and so you have an overall decreased amount of albumin circulating, which results in a decreased oncotic pressure. As far as cardiogenic causes are concerned, this normally is associated with heart failure, specifically left-sided heart failure. You should know the manifestations and the presentations of left-sided heart failure. But what's basically happening is that you have an increased hydrostatic pressure that is occurring secondary to this left-sided heart failure, resulting in accumulation of fluid. First, it's going to occur in the lower lobes because that is where the hydrostatic pressure is highest due to gravity, and then even in the upper lobes. And so morphologically, you'd imagine we have heavy lungs that weigh about 1.5 to 2 kilograms with bubbles of water seen in autopsy. And then in the cases of long-standing pulmonary congestion, so in long-standing pulmonary edema and pulmonary congestion, you can have something we call brown induration, which is characterized by the presence of hemosiderin laden macrophages. These are abundant in this case, and the presence of these hemosiderin laden macrophages with fibrosis and thickening of the lung walls results in this firm and brown appearance that we call brown induration of the lungs. I'm not really going to bother going into details of how these hemosiderin laden macrophages come into the picture here with the heart failure. That is something that is 100% going to be covered in the heart failure part of general pathology. But for now, if you already know it, well and good. But yeah, that's all there is to it really. Brown induration is just caused due to hemosiderin laden macrophages being present, and then secondary fibrosis and thickening occurring of the alveolar walls with respect to a lot of fluid being present in the lungs. And so for the fourth type of pathology we need to discuss, which will be a relatively quick one, is diffuse alveolar hemorrhagic syndromes. And there are two within these that we need to discuss. The first one is what we call good pasture syndrome. And this is normally characterized by the presence of autoantibodies being produced against type 4 collagen that is found in the basement membrane of the alveoli. And that's all there is to it. This is more associated with renal pathology as well, so there's no real worry into going into too much detail. All you need to know as far as good pasture syndrome is concerned is that you have autoantibodies that are being produced against the type 4 collagen present in the basement membrane of the alveoli, and as such the presentation of this, as it says, because it's a hemorrhagic syndrome, is that the patient presents with hemoptysis. And the second disease that causes diffuse alveolar hemorrhage is granulomatous polyangiitis, which for now what you need to know, or you already probably know a lot more about from vascular pathology, is that it is just a necrotizing granulomatous vasculitis that has presentations with respect to the pulmonary circulation as well. And that should basically cover everything that you should be able to talk about in this question. I hope this helps.